racism in children's health, we can see it divided into 4 levels. Internalized racism lies within individuals. This type of racism comprises our private beliefs and biases about race and racism, and it's influenced by our culture. It can take all kinds of forms, including prejudice towards others of a different race, internalized oppression, which would be negative beliefs about a person by people of color, or internalized privilege. Those are beliefs about superiority or entitlement by white people. Interpersonal racism, which is also known as personally mediated, occurs between individuals. And this is the bias that occurs when individuals interact with others and their personal racial beliefs affect their public interactions. When we talk about institutional racism, that occurs with institutions and systems of power. And that applies to our universities, that applies to our hospitals. And it refers to unfair policies and discriminatory practices of particular institutions, even schools, other workplaces, places that are routinely producing racially inequitable outcomes for people of color and advantages for white people. Individuals with institutions take on the power of the institution when they reinforce racial inequities. Structural racism is the racial bias among institutions and across society. This involves the cumulative and compounding effects of an array of societal factors, including history, culture, ideology, and interactions of institutions and policies that systemically privilege white people and disadvantage people of color. Implicit bias can shape the way medical providers interact with children and their families. Because everyone is susceptible to implicit bias, even clinicians, that includes all of us participating in this webinar today. These unconscious preconceptions can naturally seep into our communication with families when we're at them at bedside or in the office setting or the hospital setting. With any interaction, implicit bias can have adverse effects on the patient experience, and I'm including children and families. We can damage patient and provider interactions, and implicit bias can impact health outcomes. So in a lot of situations, patients are able to pick up on a provider's implicit bias without the provider thinking of it or the provider even being aware of it. And when we look from a quality improvement standpoint, patients often report a poor experience of that. Naturally, a patient who picks up on a provider's implicit bias may feel less inclined to really deeply engage with their own care and the relationship with their provider. In addition, it can put a cap on how well a patient understands his or her own health, their child's health, or how much they're invited to participate in the care, or how they're respected in the care that they provide for their child. For example, some providers may limit the depth of shared decision-making with adolescents or explanations of medical concepts because their implicit bias tells them that patient doesn't have the health literacy or the age to fully engage with their care. That's implicit bias, an example. Coupled with some implicit biases that tell providers a patient may not be able to afford specialty care, that can decrease in odds that a patient gets the depth of medical care that they might need. There's a quote that I really like from Stacy Millett from the Health Impact Project, and I like how she phrases it. She says, a lot of implicit bias training could just start from the awareness that we all, every one of us, have some kind of implicit bias for many, many different reasons from how we grew up and what we're supposed to do. But it's all about how we behave and what we do. Now, another component for you to be thinking about the work that you do with children and their families, especially those with chronic illness. I work a lot with children with serious illness, but this is applicable also for acute illness, is thinking about health literacy. And that's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. When we think about Joint Commission standards, and all of you working in a hospital or going to work in a hospital, you know of Joint Commission, thinking about the materials that we give to families are meant to be by Joint Commission standards at a 4th to 6th grade health literacy level. And I want you right now to think about the forms that families are filling out when they come in for an outpatient visit. Maybe it's the first time they're seeing that physician, just like you or I, any of us who've seen a new physician and you have maybe 2 to 5 pieces of paper you have to fill out. think about how high that health literacy can be on there. It's not necessarily a 4th to 6th grade reading level. Oftentimes, the information is pretty sophisticated at a 10 to 12th grade level. Health literacy levels are impacted by socioeconomic status. It's impacted by English language proficiency. So think about when you're working with families, such as about 46% of the Santa Barbara County is Spanish speaking. They could be monolingual, they could be bilingual. But thinking about when they come in to fill out paperwork, how fluent are they in English? Are they saying that their primary or preferred language is English only because maybe they don't want to draw attention for any other reasons, because they might be documented, they don't want to stand out in a crowd, when actually when they go to do that paperwork, they might be thinking to themselves that they aren't as confident with the information, understanding it, as they may have expressed to the person behind the desk.
So for example, do they have interpreters, right there in hand? A lot of the time, something that we notice, for example, here at Teddy Bear Cancer Foundation that we hear pretty often is the parents. We have a little bit over 54% of Spanish-speaking clients that we help out. And we hear a lot of the stories in which the child themselves have to be the interpreter for the parent. We've had cases where the sibling themselves had to actually let the parent know that their sibling was diagnosed with cancer. So there's a lot of different things that also comes into it, and how much it impacts them. Something that people also notice, or families will notice in this a lot of the times, is how comfortable they feel speaking to their healthcare provider. I know Rebecca mentioned something that is really something that we do hear a lot, is because they don't feel comfortable because of their document status here in the United States. So here there is a quote that says, Hispanic Latinos often encounter cultural and language barriers when seeking and receiving healthcare, which impacts patient-provider communication and crucial component of quality healthcare. Something that they also noticed within this study right here that I was reading was that a lot of those families, that they said that even though they felt like the healthcare quality was amazing, they felt like they were taken care of well, they also felt that if they spoke English, they feel like they would have a little bit more knowledge. Also, what is going on with any clinical trials that they may have and how they feel.
So first, I want you thinking about how you assess a family's communication preferences. And that can differ between culture, it can differ between language, religion, belief system, but it's looking at every family is different that we work with in a hospital or a community setting. It can be their own family culture. It can be based on the belief systems that family practices. It can be based upon their traditions. It can be based upon their genders. It can be based upon roles in the family. It can also be based upon coping skills. I always think about when I was trained in child development, down at the 0 to 5 age, and I think about when I communicate with families in the hospital setting, that if I have the basic skill set of speaking to a child at a concrete level, that can be successful in a medical crisis with adults and children. And it's thinking about how do we present information in a clear and concise way. But it's thinking about, is there a person in the family, maybe there's a patriarch, maybe there's a matriarch, that is the lead of the family? Is there one person that we go to? It's thinking about eye contact. It's thinking about roles. When I used to work in New York City and work with Hasidic families, I needed to recognize and learn quickly in my years of working in New York City and working with Hasidic families whose children had cancer, that I was not Hasidic. I was also a woman. And the role I played in the care for their child in the hospital setting was different than that of the male physician, the well-respected physician. And it's really looking at each family and thinking through, how will they respond best? Who will they respond best to? Is it a certain member of the medical team? Is it the physician, the social worker? Should I be speaking with the male family? Should I be with the female in the family? Should I be making eye contact? Who's comfortable with eye contact? And in terms of thinking about language, both in terms of your words and body language, that is something that I am always being very cognizant of in terms of whatever I'm communicating or I'm intimidating in a meeting through my words, time, families are looking often and learning right from the beginning at my body language. So it's, again, thinking about those different families, their beliefs, their tradition, their culture, and making sure that we take the extra time to consider it and respect it in the work we do with families. So another piece to look at is evaluating a family's decision-making styles. This can vary between families of different cultures. And I'll give you an example of a family working with actually on Tuesday. This was a family, actually it was an adult patient, but the family was Persian. And one of the pieces that came up immediately as I was working with social workers and case managers, and we were talking about the conversation we would have with the family, was a comment was made that the patient didn't necessarily have capacity to make healthcare decisions. And capacity to make healthcare decisions is something that's important to learn about. But it's whether a person understands their situation, whether they know their self, whether they understand the risks and benefits of treatment and how they're moving forward in the type of care that they're receiving. And as I was working with this family, and I was told that the female patient didn't necessarily have capacity, I was so appreciative in working with the bilingual facilitator on my team. She's Spanish speaking, but she said to me, we both looked at each other, we said, this woman seems like she certainly has capacity to make healthcare decisions for herself. She can carry on conversation. She knows where she is. She knows what's happening to her body. Why is it being said that she doesn't have capacity? What we realized in observing the family and in talking with the nurses and social workers, that in this family structure, their specific family, their specific belief system, it was the husband and the adult son who make all decisions in the family. So even though this was the female patient herself being there in the hospital, she was listening, but she wasn't vocalizing. But that was tradition for her. And it was how she related to her family, how they respected each other, and how we observed that, and how we took the time to learn that actually this is this family's style. And they do have a communication pattern. This woman is communicating her needs to her husband and her son privately. And then in the group setting, when we meet with the physician, it's always the husband who's speaking. So I give that just as an example because what struck me was first somebody said that this woman didn't have the capacity to make healthcare decisions for herself. That wasn't it at all. She had capacity. It was looking at their family style of making family decisions, which for this family was dependent upon their cultural and faith-based beliefs. So it's really important, I think, as we work with families for difficult meetings and we look at who's making decisions, is to step back and to look at the family structure. And one of the most important things to do is ask. When we don't know the answer, I think that can only benefit us when we are humble and graceful and we ask the family, tell us, how do you make decisions in your family? How do you like to give input? What is the best way? Who's the person that we typically go to? Who is the person that has the role in decision making? Is there one person that usually speaks? And it's really important when we're practicing cultural humility that we acknowledge when we make an error, because we will all make an error. I only continue to learn in the work that I do now. And I find that if you want to build trust with families, you want to build trust with communities, it is being open, it's being respectful, and it's also acknowledging when we make an error. And when we make an error, remembering that so we don't do it again.